External respiration is defined as a process of gas exchange between the lung and the pulmonary capillary blood. As opposed to internal respiration, the gas transfer which occurs between the arterial blood and the tissue cell. In this 43-minute presentation, a quantitative description of external respiration is developed, which explains how the members of the intensive care unit team can calculate the prevailing shunt as a percentage of cardiac output. The equations which govern these processes are formidably complex, but an internet-accessible computer application or app can be used to generate the pertinent data in real time. There's no other place except this module where users can explore the physiologic concepts that were used to generate the app, as well as the instructions whereby ICU teams can access the app and apply it in real time at the bedside. Classically, hypoxemia can be elicited by 1, a reduced level of oxygen in the ambient air, such as is seen at extremely high altitudes or as a result of suffocation. 2, ventilation perfusion mismatching. 3, diffusion defects, such as might be encountered in the context of pulmonary fibrosis. And 4, intrapulmonary shunting, that is seen, for example, in patients with ARDS. For hypoxemic patients in the ICU, the last 3 of these conditions, either singly or in combination, can trigger hypoxemia during air breathing. Ventilation perfusion mismatching and diffusion defects can be abolished simply by increasing the inspired oxygen fraction, or FiO2. But many, if not most, ICU practitioners are unaware of the extremely modest enhancement in FiO2 that is required to completely eliminate the contributions of those 2 disorders. In this lesson, we will examine monographs in the peer-reviewed literature that reveal that an FiO2 of merely 0.35 will succeed in abolishing any contribution the VQ mismatching and diffusion defects might have made to the hypoxemic state that prevailed during air breathing. Hence, in those patients for whom FiO2 elevation is observed to result in an elevation of the arterial PO2 to the desired range, this approach proves to be both diagnostic and therapeutic. In the remainder of patients in whom hypoxemia persists, in the face of an FiO2 of 0.35, the presence of shunting, defined as perfusion without ventilation, is confirmed. Although we commonly conceptualize shunting as a distinctly pathologic condition, the lesson will enumerate the physiologic origins of the 2 to 5% shunt that is observed to prevail even in normal subjects. Dr. Barry Shapiro and his colleagues performed an intriguing and elegant study of intrapulmonary shunting at Northwestern University Hospital and reported their findings in a seminal monograph that was published in Chest in 1980. They acquired 124 ABG datasets from hypoxemic patients whose FiO2 was increased from 0.40 to 1.0 and plotted the PO2 on the ordinate versus the shunt expressed as a percentage of cardiac output on the abscissa. Because none of these subjects had been previously instrumented with a Swan-Ganz pulmonary artery catheter, Shapiro's group was forced to estimate the arteriovenous oxygen content difference and chose to set it to 3.5 milliliters per deciliter. In another 16 patients who were equipped with an indwelling Swan-Ganz catheter, the FiO2 was raised from 0.50 to 1.0. The arterial PO2 versus shunt in this subpopulation was similarly plotted both for an estimated AV difference of 3.5 milliliters per deciliter and for the actual and variable AV difference that the presence of the catheter enabled them to measure. Surprisingly, the figures obtained using the actual AV difference and the estimated AV difference were virtually identical. This implies that in those patients who have not already been instrumented with a pulmonary artery catheter, the percentage shunt for a patient under our care can be closely approximated by assuming an AV difference figure of 3.5. Whether we estimate that parameter or have access to its actual value, we can employ the shunt determination ClinimapEd that is accessible free of charge from the internet to calculate shunt. The key to enabling the ICU team to do this is an equation developed by a brilliant British mathematician, G. Richard Kelman, upon which the app is based. We would respectfully suggest that a fundamental understanding of pulmonary gas exchange is extremely important if RCPs hope to intelligently evaluate the changing conditions of the patients to whom they are assigned. On occasion, the ICU team might prefer to measure percent shunt in serial fashion over the course of a patient's ICU stay. The module demonstrates that to the extent that the team opts to do this, shunt figures can only be compared when calculated at a given FiO2 value.